Thank you. Okay, so now we wanted to work through some of the goals for today's meeting. So starting off, I just wanted to thank all of the folks who have helped to organize today and tomorrow's activities, especially Jyoti, who has served as our executive secretary and really helped make this meeting happen. And then today, so far, what we've heard is some information about NHGRI's strategic planning process. We've then heard from Heidi and Mark a little bit about the state of the science today and where genomic medicine is. So now where we really want to be able to turn is towards what is our vision for the future. We've been having a number of town hall events as we work through our strategic planning process at NHGRI, and so far what we've heard from the community coming out as a vision for genomic medicine in 2020 is to really work towards being able to have, let's see if this works, genomics integrated into clinical care so that all individuals can receive genomic information and be able to use it for their health care, whether it be the patient being able to utilize this information or any of the individuals that might be working within the care community. So we've identified 6 themes, which are what we're going to be talking about today. And so each of these themes does overlap in some ways because we really are talking about a broader process. So we understand that if we start off really thinking about the first theme, looking at being able to create systems to integrate genomics into everyday clinical and public health practice, then overall, it's going to lead into needing to be able to improve the actual test itself, and then into the actual databases that we're going to need to be able to make that test happen. So our goal in our conversations, talking about these 6 themes going forward, is not to necessarily focus on making sure that every presentation is exactly fit and all the comments are within each of the themes, but really to be able to drive discussion and conversation around this area of genomic medicine by tailoring our conversation into each of these 6 theme areas. So what we're going to be doing today is starting off with an introduction for each of the themes. This introduction is going to be given by a member of NHGRI staff. And what we're going to do in that introduction is just basically outline for you what we've heard so far around this theme and outline for you what we're considering to fall within that theme area. After that, we're going to have a series of 3 or 4 talks, which will each be 5 minutes. What we're going to ask everyone to do logistically is for the introducer, for all of the speakers in the session, and the moderator to come to the front of the room at the beginning. That way we can just pass off the mic between each of the presentations and try and keep our conversations flowing. We'll wait to hold comments and conversation on all of the talks until we get to the discussion at the end of each theme. So we'll have a brief introduction, our 3 or 4 presentations of 5 minutes each, and then we have about 40 minutes for discussion of each theme. Just to let everyone know, we do have some time built into the agenda tomorrow to be able to talk about anything that we missed. So if you bring up something that does seem to be a little bit tangential to the theme that we're discussing, we have individuals in the audience who are capturing those ideas for our discussion tomorrow, and we'll start a parking lot of those ideas to be able to hold for our discussion about anything that's not covered by these 6 themes. Then the other element that we're going to be continuing to do are these more interactive elements. So thank you everyone for answering our barriers and opportunities questions this morning. We're going to go through the results just shortly. Just to let everyone know, we are planning on having another interactive exercise tomorrow over lunch. Those are the questions which are available on the meeting website or that were sent out to all of the attendees here today. That'll just let you preview the types of questions that we're going to be asking everyone to complete over lunch. And then we'll have the results presented right after lunch tomorrow. We're also going to have another set of these same barriers and opportunities questions at the end of the day, just to see if people's opinions have changed at all from where we started the meeting this morning to where we get to at the end of our day tomorrow. And so with that, I will stop briefly to see if anyone has any comments or questions just about our logistical process, and then we'll move on to our results so far. So any questions? Okay. then we will move on to our results from the barriers and opportunities. So what we're going to do here is bring up the actual results from the 2 questions that you answered this morning, talking about what do you think is the #1 barrier to genomic medicine implementation and using genomics in routine clinical practice, as well as a second question looking at what are the opportunities for being able to use genomics in routine medical practice. What we have available is a word cloud, which we're going to look at just kind of where some of your different answers came in. And then there seem to be some themes that were coming up in these presentations that we can look at to be able to see the results so far. And so while Jyoti's pulling up those results for us, one of the things that I noticed from the results so far was that the overall barriers tended to all be focused on a lack of information. So a lot of times what people were focusing on was that there was a lack of knowledge, a lack of information about outcomes, as well as potentially a lack of just information and training out there on how to be able to utilize that genomic information for care. So then if we pull up those word clouds under the results, okay, there we go. Awesome. So now you can see lack. So basically, a lot of the words that you see around here were all associated with this overall idea that there is a lack of data, there's a lack of being able to necessarily understand all of the outcomes, that there's a lack of education that's available, as well as support and coverage for being able to do the testing itself. So overall, in many of these barriers, what we were really hearing from folks was that we have this testing that's available, but that it's hard to necessarily be able to have some of the training, that it can still be difficult to be able to get this covered by insurance when we're talking about routine clinical care, and that we're still missing some of the information about how this is going to be utilized and what the outcomes are going to be. Another piece that came up in a number of the responses was about access and how do we actually implement this? How do we have connections to the community? And so there were a number of replies as well that came up talking about how we needed to be aware of how is this information going to be utilized for all members of the community? How can we make sure that everyone has access to this information? And how can we make sure that we build an infrastructure that's going to make it possible for this type of information to be used for everyone in clinical care? And so I think I'll stop there as far as just some of the brief responses that came in and see if anyone has any comments that you would like to share about the responses that you put in. So any thoughts about the barriers question? Yes, in the back.
So, I don't want to disagree with the broad consensus in the room. We'll never have a complete set of function around genetic variants. I mean, we're always going to be discovering new ones, and the idea of waiting until we have more data to implement is not the right approach, I think. So my contention would be that we actually have lots of data. And the barrier is figuring out methods or mechanisms to implement what we know. And that doesn't mean we should stop discovering, but I'm responsible for the word infrastructure at the top, which is in the least bold notation, and I would argue that should be bolder, because we have stuff that we should be implementing and we're not.
Thanks, Dan. And one thing I will note is that because we are displaying these just as a word cloud here to be able to make it a little bit easier for people to be able to synthesize the results from this morning, we do have all of the responses and the actual text that came in from everyone. So we can see the context of all of these results. So in some cases, what ends up being highlighted, for example, the word lack ends up being much stronger because it's something that came up many, many times across many different areas. Indicating that someone might not necessarily feel that there's perfect knowledge doesn't necessarily mean that they were also indicating that what we have right now can't be used, but just that there might sometimes be barriers towards needing to have more information available to be able to maximize the use of genomics. So we'll be able to go through all of those responses as well. Yes, Bob?
I'm just going to follow up. That was a really interesting point just made, and I wanted to sort of bounce back and say, can you give us an example of one thing that might be actually pretty easy to implement that would have a significant impact?
Did I say anything was easy to implement?
Well, not everything is easy.
But I mean, so
maybe one thing that people can focus on.
FH testing in people who have myocardial infarctions when they're 42 years old, I think ought to be part of guidelines for practice. I think pharmacogenetics ought to be implemented. How to do that is harder, but there are some centers that are trying to do that, and learning from those centers is another way of thinking about it. But I think there are genetic variants that we know about that ought to be driving practice and aren't. Mark's example of people who ought to be tested for cancer susceptibility variants in their germline and aren't being tested, those are opportunities that we're missing.
Okay, let's do Jeff and then Colleen.
Yeah, I think we need to get a little bit more granular about what we mean by implementation and evidence, because at least my perspective is that there's a certain amount of evidence that's needed for what I might call preliminary implementation, and then you use that first phase of implementation to generate the evidence that might be useful for adoption and dissemination into guidelines. But so what is that evidentiary threshold that we need to begin to think about implementation in a much more clinical research oriented way, and then how do we build the evidence base that allows this to actually be useful for the broader communities that we serve?
Thanks. And Colleen?
Actually, I have a follow-up question to Dan's, because in my response was very similar to Dan's. I think there's plenty of stuff we already have evidence for. It's how do we make it actually happen? So when you were saying that there was a common theme of lack of info or lack of evidence, was that actual, causality or genetic evidence, or was that more lack of expertise among our colleagues in medicine, lack of info about how to implement? I guess I just need the rest of the lack of info about.
Yes, so this is generated just from the responses that people put in this morning, which were all limited to about 200 characters. So they're going to be broad statements. A lot of what I was looking through the results just earlier, and it looked like there were a number of them that were related to wanting more information about education and knowledge and having this available. So you'll see education was also up there as a high point. I think it's going to be hard for people to be able to read all of these on the screen right here, but you can see that a lot of it was more to do with lacking that knowledge and information for education and care, and then also really wanting to be able to see that that was built up more, that this was a barrier to being able to implement in the future. Yes, okay. And then we'll go to Alicia.
So coming at it from the patient perspective, like I always do, I also think that the language matters and what we mean by evidence versus utility versus outcome and impact, that matters. Yep. I think just knowing about a genetic mutation that's fully validated and you have a lot of knowledge about it, but the patient has nothing that they, like the options for them might not be there on what to do with that, or it might create more anxiety, or it might be something that they would not want to do. I think that's where the disconnect comes a lot of times. So language matters, and so what you mean by like data, information, knowledge, utility, clinical utility, and then outcomes. And I think the outcome area is where I really saw lack of information on.
I think that's a great point, and that's what we're really hoping that we'll be able to dive into in the next day and a half, is that as we start going through these themes and hearing people's ideas, that we'll be able to take this, which is a very broad strokes, what do you see as big barriers and opportunities, activity, that's really just synthesizing at very high level words and language, and really dive down into these 6 themes and hear from people, where do you feel like these opportunities are, the ideas, thinking more about where can we have an impact going forward. I saw at least one more.
Yeah, I think along the this theme. I really feel like, and sort of looking into the detailed responses, I think it was reflected there as well. I think in this room, and what Heidi and Mark both highlighted, is that there is evidence, but that currently there lacks sort of the adoption by the provider community, by the medical community, by guidelines, by payers. There is a lack on those things that keeps it hard for patients to get access to the information, or makes it so that providers are uncomfortable distributing or ordering genetic testing. And so I think maybe from my point of view, it's there are certain areas where the evidence is there, but the lack is in all of the other sort of infrastructural pieces. So really very much what Dan said. And I think that is reflected in this word cloud. It's just maybe kind of hard to parse out.
Thanks. So Ivakar and then Jillian.
So I think just to provide, I'm an actively practicing clinician, and just a broad theme that whatever we do, in the end, if we want to improve patient care, it has to funnel through the healthcare team, namely the physician. And I think physicians are a bit overwhelmed. The electronic health record hasn't really improved their life. It's caused more burden of documentation. Data is being generated at an enormous rate, and medical practice changes very rapidly, and there's a huge burden on physicians. And if we want to ram more genomic data down their throats and say, you got to do this and that, I think systems and procedures that make it easier for physicians to implement what we learn is critical. Otherwise, I don't think that no matter what we do, it's not going to go to the patient care outcomes.
Thanks. And Jillian?
Yeah, also jumping on the same team infrastructure bandwagon here. I think there are examples of tests that have rolled out and implemented very, very rapidly. And to me, one of the sort of commonalities there is that they rolled out on an existing infrastructure of delivery. And the two big ones that I would think about, I spend a lot of time watching claims data and watching tests across the country, across states, rise in volume. And the two biggest ones over the last few years have been non-invasive prenatal testing, which was offered to many people who were previously getting maternal serum screening, and ultrasounds. So there was a time and a place to offer that test across the clinics that it allowed it to be introduced. And the other one that's even faster than non-invasive prenatal testing is Cologuard, which has, over the last 2 years, just gone into the millions of people who are getting access to this test. And again, I think it builds into an existing infrastructure. And I think many of the other tests we've talked about don't have this similar infrastructure or point of entry to introduce it. It's unclear there. And so I think it's important to think about that.
Great. So I think we've unpacked a little bit here about our barriers words cloud. So I think we can move on to our opportunities to close us out for this morning's session. So then as we move on to looking at the opportunities, one of the things that we found was that this word cloud then is more focused on the patients and being able to really show decisions, that they want to be able to change outcomes. People want to be able to help support people being able to make health decisions. And a lot of the responses here were very positive around the opportunity being around being able to take genomic information and data in order to be able to improve overall decision-making processes. Some of these were more focused on being able to bring the patients into these decisions. Some of the responses focused more on being able to potentially move this into other areas such as preventative care and decision making. And some focused a little bit more on the idea of being able to choose your outcome or treatment, or how to be able to integrate this with a care plan. But a lot of the results that we got on the opportunity side were around this idea of utilizing genomics to be able to improve decisions in the clinic. And so I think I'll stop there and see if anyone has any comments that they want to make on these comments and the words in the opportunities word cloud. Yes, Bob.
Just an observation that sort of, and it's come up, I think, in a later theme about using genomics for therapy, and doesn't really come up here, and wondering whether that's just because this collection of individuals is mostly a clinical group rather than a therapeutic development group or not. I don't know, but I just thought that was an interesting bias in a way.
No, that's an interesting comment. And I think we are going to explore that a little bit more throughout the meeting, as well as in our interactive again tomorrow. Any other comments? Yes, please, Jeff.
I guess I just would like to emphasize the points that both Heidi and Mark made earlier about the opportunity to create a truly learning health system focused on genomics, which is very bidirectional, really driving a discovery engine as well as propelling those discoveries into clinical care.
Yeah, that's a great point. And you can see some of that coming out with this idea of, looking at technologies and really wanting to be able to increase things and create new tools and methods. So there were some comments about that, but it's a little bit harder to see them in this particular cloud. So that's a great point to bring up. Heidi?
The question about focus on therapeutics, one way to look at this is, well, we'll let the therapeutic world develop things, and once they have them, we'll then try to implement. But the truth is that a lot of these companies are looking for guidance as to where there's high frequency of genetic disease so they can focus their energy. And that's actually not an easy question to answer, is what the prevalence of disorders are. And I think, the prevalence of a fully fledged rare disease diagnosis may be much lower than the prevalence of individuals who have a wider variety of spectrum of phenotype. And so I think we could help the therapeutic space by better documenting and describing the true prevalence of disease and the full spectrum of phenotypes as a way to then feed that into the therapeutic industry to say, hey, you may think this is rare, it's not that rare. And here are some of the top disorders that our patient populations actually have, and that would be a worthwhile investment in the therapeutic realm. So I think we should not just assume they're going to all figure it out, all this out on their own, and that there are opportunity for us to push that better.
I think that's a great point. And we will have some time on theme 4 where we're talking about therapeutic strategies, as well as one of the questions for the interactive tomorrow that people can think a little bit about is really asking, should NHDRI be involved in this therapeutic space? And if so, we want to be able to have some discussion about how people see NHDRI potentially playing a role in helping with therapeutics going forward. Any other comments about opportunities? Yes, please, Milan.
I'm not sure if this is a barrier or an opportunity, but I was thinking about what Mark said about having sequence data stored, and here we are talking about using technology, using this data, right? But something we need to consider as we do all of this is patients' privacy and security. Genomic data, along with the rest of the data, it's like a hacker's dream, I guess. So that's something we should be cognizant of as we think about solutions.
That's a great point. And I do think that we are going to notice as we go through a number of the talks over the next 2 days that some of these barriers can also be turned into opportunities. So I think that would be a great place for people to also be really thinking about, if we identify things as a barrier, are there places that we can then also have discussion about what we should be doing in the future to be able to help break that down? And Mark?
Yeah, another hot button that just got pressed related to privacy. As I mentioned, we've had extensive consultation with our patients about this, and what's really fascinating in all of our focus groups is that the issue about concerns about privacy or genetic discrimination never came up in the focus group unless it was one of our healthcare providers who happened to be participating in one of the patient focus groups. We have done a spectacular job of sensitizing people that this information is somehow really different and really scary. And we've had a recurring habit in healthcare of doing this to the detriment of patient care. And we did it with HIV/AIDS, and we've done it with mental health. And what ends up happening is we sequester information that could be used to help patients on the basis of hypothetical harms, which rarely, if ever, actually come to fruition. If you look at the literature about the number of times that genomic information has been used inappropriately to harm people, there's almost no examples of it. And so while I'm not saying we should ignore this, I think what we have to do is we have to contextualize it so that we don't harm people by not doing something because we're concerned about a hypothetical. We need to have an agenda around making this rational and not just getting everybody upset. And the other thing I'll just mention about this is that there's been a lot of concern about, well, if we give this information to people in an unsolicited fashion, they're going to get really upset, it's going to disrupt their lives and this sort of thing. We've been measuring that. We've had almost no examples where people have said, this is really terrible and I don't know what I'm going to do. And in fact, again, going back to our focus groups, as we brought up these scenarios about, well, we're going to be giving you information that you may not have been expecting, they said, well, wait a second, isn't that healthcare? I go into the doctor's office all the time and they find something that we weren't expecting and we just deal with it. So why are you guys making such a big deal about this? Or and again, maybe our patients are just clueless, but I think that they probably represent a little bit more reality than those of us that think up doomsday scenarios all day long.
Okay, so that definitely got us some more comments here. So we have just a few minutes left. So in the back, we have. Yes, please.
There's a low-hanging fruit that's existing right now, the CMS bill for genetic counseling added to Medicare, Medicaid, and advocacy-related efforts. I think this group perhaps is certainly on board with that, and there are also restrictions for government agencies to be involved in that type of thing, but as citizens of the community, I think there's some opportunities there as well.
And then there was a comment behind you?
Yeah, just to follow up to what Mark was saying, and I think Les has really talked about this also, is we, I think, as a community in medical genetics, haven't normalized, we've kind of kept this box around genetic testing, and it's been something that's different. And I think a big first step into introducing, really implementing this into healthcare is to normalize it. It's a test. I mean, to Mark's point, we give bad news all the time from other types of tests. And so normalizing this into routine healthcare and providing physicians the tools to know how to use it and when to use it, I think is going to be a big first step here.
And then I think Patty was in the middle. We'll give you the last comment.
So as a patient who has actually made the decision on whether to get testing or not, it's not just you that you're affecting, it's also your family because it is inherited. And that's what I think makes it different and more protected, and it tells a lot about you, right? So I even, delayed BRCA testing until my daughter was ready for that answer because it wasn't going to help me. I had a bilateral and ovaries out, so it wasn't going to help me, but it would affect my daughter and my sister. And so, I waited years before I got the BRCA and then the panel testing. So it's not a blood test. It's not a white count. It's not a, liver test. It's very different. And I think privacy is an issue, but I think it's really about explaining to patients the benefit risk because, if there is a benefit, then it is worth it. And I think you get different answers as well. I'm in the cancer community, and cancer patients do whatever you want to with my data because I want to cure other cancer patients. But when you go into surveillance into the general population, I think that's a different discussion. And so I think it's about really valuing the patient and doing that consent in full view of what could happen.
Comment?
Thanks.
Maybe contextualize this. I think this highlights a big picture issue that we could really benefit from this group's input on. I think a lot of this has to do with the risk-benefit calculation of how these things are implemented. And there's two approaches to improving that ratio. One is to reduce risk, and the other one is to increase benefit. And so input from this group broadly on the balance and the ways in which one can do those two things would be extraordinarily useful output of this session.
So I'm going to have to cut us off here, unfortunately, because otherwise people aren't going to get a break. So we have until 11:15 for people to have a short break. If you want to be able to go out and grab a cup of coffee, restrooms are located around the corner here. And then we will be coming back to be able to start off our theme presentations. As I mentioned, we will be coming back to this barriers and opportunities on day 2. So if you have other thoughts, there will be a second opportunity to address these questions tomorrow. So thanks everyone, and be back again at 11:15.
No, and I think there's actually